Hi, everybody. Today we're going to talk about rounding in the ICU. The target audience for this video is anybody who's going to be participating as a member of an ICU team. That may include medical students, advanced practice practitioners, attendings who perhaps don't usually function in an ICU role, but are stepping into that to help take care of a surge of patients. And most commonly likely it will be for residents. This is predominantly based on our surgical or trauma ICUs, but is also applicable to medical ICUs as well. So when it comes to thinking about rounding in the ICU, it may seem overwhelming at first because it's a room full of very sick patients. However, it's actually very methodical, and the most important thing is attention to detail. So what we're going to focus on is what you need to be thinking about when you're pre-rounding, and then when you're presenting on rounds, and then what you need to do after rounds. The process of pre-rounding happens before the team rounds as a formal group, and that predominantly is data collection, but it's also a thorough exam of the patient, putting in basic orders, and also collecting your thoughts to make preliminary plans. You should use some sort of template in doing this because that does make sure that you don't forget any important information. People have a variety of things that they prefer to use. If you do a Google search, you'll find a whole host of options, and these are some of them in front of you. Or you might find that it's better to either make your own or use one that a colleague in your ICU has used and found to be successful. Sometimes it can be institution-based or intensivist-based in terms of what format will work the best to make things go smoothly. I use my own, but everyone has a different style. Doing your data collection in the morning as part of pre-rounds is one of the most critical things that you're doing. And this is, again, where attention to detail is very important. For vital signs, you need more than just what you see when you walk in to see the patient, but you need a full 24 hours. This also means more than just what you usually find in the flow sheet for the past 6 or 8 hours. This might be on a paper flow sheet, or it might be in the electronic medical record. Again, that depends on your institution, but regardless of where the source is, you need to make sure you're looking at a full 24 hours, and that might mean going back into the paper book chart or somewhere else to get that information. You'll also want to collect all the I's and O's for the patient. This means all of their intake as well as all of their outputs. So as far as intake, their current IV fluids, tube feeds, any TPN they may be on. You need to know what types of fluids or tube feeds they're on. You need to know the rates that they're actually receiving. For drips, they may be on pressors, they may be on an insulin pump, a heparin drip, an amiodarone drip for rate control, or a host of other things. So you'll want to look at what those drips are that are currently running, in addition to sedation. And while the volume totals do make a difference in terms of their I's and O's, as far as the rate goes, the actual dose rate is what we're interested in that we consider on rounds. So for example, the mics per minute would be what we functionally need to know, not milliliters per minute or hour, because that can vary by patient. You'll want to know their average hourly urine output. For adults, that's usually all you need to really know. For kids, you need to break that down by kilogram. Especially in surgical patients, it's important to know the 24-hour output of drains and tubes. We make a lot of our decisions for chest tubes and abdominal drains based on the 24-hour output. So again, you need to seek out that information. And then a total I&O balance over 24 hours as best as you can find, with the realization that there's a lot of insensate losses and there's a lot of things that still don't completely get recorded. However, Usually you can tell if somebody's grossly positive by at least a couple liters over 24 hours, and sometimes it's even helpful to know what that balance is over a few days. You'll want to look up the patient's labs in addition to trends. We'll talk more about that by system. And then you'll want to look at their most recent chest x-ray, as well as any other imaging done in the last 24 hours, taking note of when it was done. So a lot of times when you're pre-rounding, the chest x-ray won't be done yet. It's still good to look at yesterday's chest x-ray, especially if the patient is new to you, but do take note if you still need to follow up on today's chest x-ray. You'll also want to collect information about anything that happened overnight. So a good source for this would be the patient's nurse from overnight. Make sure to catch them before they leave for the day. Or the provider, either the resident or the APP who was on overnight, can let you know of any problems that they had. You'll also want to follow up on any plans from yesterday, which you will see in yesterday's notes, and any consults that were ordered and what the consultant had to say. Additionally, you'll want to look at what ventilator settings they're currently on, as well as recent changes, and we'll discuss that more by system as well. And you'll want to know if a spontaneous breathing trial was done and what the result was. And that's information that you may need to get from the respiratory therapist that was on overnight. Again, make sure to catch them before they leave for the day as well. Finally, you need to get their current med list. This is from the MAR, not from the yesterday's note. Oftentimes those notes end up being inaccurate as changes are made over 24 hours. And so you want an accurate list of the medications that they are receiving scheduled and PRN. You need to do a full thorough exam on the patient. Most oftentimes this is going to be the most thorough exam that's done of the patient that day. So do realize that responsibility. You'll want to be able to report how responsive they were, especially in the context of sedation or a head injury or a spinal cord injury. You'll want to take note of how they're interacting with the ventilator. Do make sure to look for any abdominal distension, even for patients that do not have any abdominal diagnoses, or even for patients that aren't surgical. There's still a very high likelihood of ileus and constipation, so make sure that you're examining the abdomen. And if they have an NG tube, make sure that you're interrogating it to make sure that it's functioning properly. For the surgical patients especially, you want to look at the drains. What does the output look like? What's the quality of it, the color? Same goes for the chest tube, and you'll also want to check for an air leak. These are all important pieces of information that we will need to make decisions about those tubes. Look at whether they're edematous, again, going with the fluid positivity. Check with the nurse if there's any pressure ulcers, and if there are, make sure you take a look at them. And then finally, of course, if there's any wounds or incisions that you can or should be checking. While you're pre-rounding, you should be putting in basic orders that you know need to be done. So any labs or chest x-ray that would be appropriate to order for the next day, you can get those out of the way. If you identify things that will need to be repeated later in the day, it's good to order those as well. If the institution doesn't have an electrolyte protocol, or if the patient's not on an electrolyte protocol, then you should replete the potassium, phosphorus, and magnesium, in addition to possibly the calcium. Those aren't things that you typically need to wait for rounds to do, except for in the case of an unusual patient or maybe a patient with renal failure, then you might want to wait. If you can see a need for adjusting IV fluids, that would be appropriate to do at this time as well. If the patient has adequate enteral intake, then you may consider stopping or decreasing the IV fluids if they're not needed. If the patient's no longer being resuscitated, then you can take them off of an isotonic fluid and put them on more of a maintenance fluid as well. You should be looking at the patient's blood gas and their ventilator settings and adjusting these. It's not appropriate to wait until rounds, which are 6 hours after the ABG has been drawn, to make changes that need to be made. And if you need help making those changes on your pre-rounds, then ask a more experienced colleague. And the ideal situation would be that you make those changes and order a follow-up gas, which can then be looked at on rounds. And then you can, if appropriate, encourage the nurses to decrease the sedation or discontinue it altogether so that you can get a more accurate neurological exam. Finally, for pre-rounding, you should be thinking about some preliminary plans. So if you need some guidance, start with yesterday's plans. Were they carried through? And if not, what were the barriers? Can those be overcome, or are the plans still appropriate? What were the results? And you should always be thinking, how can we progress the patient today? We want them more awake. We want them off the ventilator. We want them taking enteral nutrition, euvolemic and moving. So think about all the ways that you can move the patient towards these goals, because these are the things that will get them out of your ICU. So that concludes your pre-rounding. Once you've collected all of your notes and data and you have some preliminary plans, you'll be presenting your patient on rounds to the group. Presentation styles will vary significantly by intensivist. Some are very detail-oriented. Some want bigger picture things. Every attending, whether they want to hear all the details or not, will assume that you are looking at all of the details and acting on them. So even if an attending wants a more succinct or brief presentation, it doesn't mean that all of these things don't matter. It just means they don't want to hear about all of these things. So do continue to pay attention to all of these things, even if you're not presenting all of them. You'll take some cues from the group and from the intensivist as far as the order or depth to present on. But in general, most intensivists would want to hear a short 1 or 2 liner about who the patient is and their presenting diagnosis, any major events that have changed. But they don't want to necessarily usually hear about the vitals and the labs and the exam all on the front end. All of that stuff should go into the appropriate system as you then just jump right into going by a system fashion. In each system, you can present your findings. That would be your relevant exam, relevant labs, etc., and then a plan associated with that system. And then when you conclude, you can summarize the changes for the day or the things for the on-call person to follow up on. So now we're going to go by system, and some of the things that you should be thinking about. Keep in mind, this is not all-inclusive. This is simply a starting point for you, and you should always be checking with your colleagues, your intensivist, and reading up on these things to make sure that you're not missing anything. But these are some of the most common things that you'll want to make sure to include. Starting with the top, the neurological system. Again, you should be looking at what the patient's sedation is. And this includes everything. So the drips that they're on, including the rate, any PRNs that they've received. Make sure you're looking at the MIR and or talking to the nurse to find out how many PRNs they actually are receiving. And also look at their scheduled PO meds. Sometimes those things get forgotten about. For some of the drips, you need to be thinking about particular things. So if the patient's on propofol, you need to make sure that a CK and a triglyceride have been checked recently. Ideally, a CK is daily, and a triglyceride is at least every 3 days. And you can look at our video on pain and sedation for more details about that. If the patient's on Versed, sometimes you have no choice if they're hemodynamically unstable and agitated. However, as they stabilize, they can typically be transitioned to something else. We try to avoid Versed because of its active metabolites and also because of its propensity to cause delirium. And so every day that a patient's on Versed, you should be looking for ways to get them off of Versed. And then for all sedation and pain medications, you should be thinking about how you're going to get them off the drips. Does that mean adding more PO medications? Does that mean adding more PRNs? Lots of things to think about there. Again, take a look at our other video for more details. You want an accurate measure of what their current GCS is and relevant neuro exam. You want to think about how can we optimize their agitation or pain? Can we wean anything? And additionally, particularly for the head injured patient or the spinal cord injured patient, think about what the physical exam findings are that are being monitored or addressed, and what are those plans from the specialists. Respiratory is probably one of the biggest systems to focus on in the ICU, of course. We have 2 videos on managing the ventilator in the context of blood gases and patient presentations. So I'm not going to get into those details. Please see those separately. However, the things you want to think about when you're creating your plans and presenting your patient, you need to know what the ABG or VBG was, and you need to contextualize it with an appropriate timeline. So you need to know what the vent settings were at the time of the gas, and then you also need to know what changes were made and if another gas is due. So if a patient's currently on pressure support and you've got a blood gas, the question is, was this blood gas drawn on the current pressure support, or was this blood gas drawn when they were still on PRVC earlier this morning? And sometimes you have to seek out that information from the respiratory therapist or from the night nurse in order to determine that, because that is very important in terms of making decisions about vent changes and when to get the next gas, etc. Just as I mentioned before, it's also important to know if they had a spontaneous breathing trial. If they passed, can they be extubated? And if they failed, why did they fail? That's an incredibly important question, because if they failed for apnea or agitation, then that's something that we can potentially fix and try again the same day. Whereas if they failed because of respiratory distress and clearly a fail from a pulmonary standpoint, then we need to think about how to optimize them in other ways and determine when it's appropriate to try again. Most often, if they fail for a respiratory reason, that's going to be a next day type of thing for trying again, although that depends a little bit on the intensivist. And so you'll want to make sure to bring that up for discussion. Make sure you're looking at the current chest x-ray, thinking about optimization of both ventilation and oxygenation. From a cardiovascular standpoint, the lactate is an important measure of the patient's perfusion. So this is actually the most appropriate system to put your lactate in, not the GI system, not other random systems, but as a measure of perfusion, this is most appropriate in the cardiovascular system. You'll want to look at any trends on the lactate. If it already was normal and there's no reason to expect that it's changed, then you don't necessarily need to check it again. Likewise, if it was trending toward normal. However, if the patient all of a sudden has had a substantial change systemically, then you may need a new lactate to determine if they have adequate perfusion. If the patient is on any pressors, you should know what doses they are and kind of what the trend has been there. So are they increasing? Are they decreasing? Are they on a greater number of pressors than before, or are they on a fewer number? Again, there's a whole video on infusions in the ICU and a lot more detail about pressors there. So please make sure to see that video. But more importantly, think about why they're on pressors in the first place. So if somebody's on pressors, it usually means that they have shock. And so the question is whether that's being addressed. Depending on the patient, you may want to ask yourself if an echocardiogram would be of benefit. Additionally, you may try just a bedside limited echocardiogram yourself. And you can ask a senior colleague to assist you with that as well. Usually you can get basic information about the contractility of the heart and a little bit about the fluid status just from a very cursory look at a couple of the views. And then finally, you need to pay attention every day to whether there's any home cardiac medications that the patient is on and whether they've been started and whether they can be resumed if they have not already been started. For the renal or GU system, we're going to assume that electrolytes have already been repleted, so you don't need to dwell on that during your presentation. But you should particularly pay attention to the patient's sodium. Oftentimes their sodium is a indicator of their fluid status, and you particularly want to pay attention to whether they're becoming hypernatremic and the reasons why and whether that needs to be addressed. You also want to look at their kidney function, and the trends there are extremely important because you might not think much of a creatinine of 1.3, but if 2 days ago the creatinine was 0.6, all of a sudden that has a lot more meaning, and it's something that you need to address. You want to look at whether they're making adequate urine. And for a lot of patients, you want to look at whether they would benefit from diuresis. So in the surgical ICUs at least, our typical approach is if we're not actively resuscitating them anymore, then we're trying to dry them out. And so even if they're not grossly edematous, they likely still are fluid positive, as most of our patients do receive a resuscitation day one from either hypovolemia or bleeding or sepsis. And if they're a few days into their course, then oftentimes they're mobilizing that fluid and can use a little help with offloading that fluid. And so every day it's worth asking whether the patient should be diuresed. On the other hand, if you have a patient who has end-stage renal disease on hemodialysis, then you want to be looking at what the access is, make sure you know that, and find out when they last got hemodialysis and when the plans are to dialyze them again. If the patient is on CRRT, or continuous renal replacement therapy, then the question is a few things. First of all, making sure that it's continuing to work properly. If the patient has any ultrafiltrate, meaning are we taking any fluid off, and that's usually anywhere from 25 to 200 mLs per hour. And just like we try to diurese patients as soon as we can, we do try to offload them with the ultrafiltrate as much as we can. So you always want to look at whether that can be increased. And eventually you want to see if they're ready to come off of the CRRT and be switched over to either conventional intermittent hemodialysis or perhaps no dialysis at all if their kidney function is improving. And then finally, as the patient really improves, you should be asking yourself every day, do they still require a Foley catheter? From a GI standpoint, you want to look at whether the patient is meeting their nutrition goals. So when is the last time their nutritional status was assessed? And that is with regards to their goal rate as well as other nutritional measures. Prealbumin is far from perfect, but we don't have a lot of great measures. So you do want to check that every so often. And you want to make sure that they're on the appropriate nutritional formula if they're on tube feeds in the context of their comorbidities and the status of their hospitalization. If the patient's on TPN, you should always be asking yourself if they still need to be, and when can we feed the gut? And that may involve discussing with the surgeon or other consultants regularly as far as when that can happen. You may consider whether LFTs have been checked, and do they need to be? So if the patient is a liver failure patient, that's particularly important. But even just a sick patient from septic shock, you can get a shock liver or some acute liver injury, and that's something to be trended. Also, kind of going back to the neurological system, if the patient does have liver failure and they aren't awakening, do make sure to think about an ammonia level as well. Another thing for all patients is ensuring that they're on a bowel regimen if it's appropriate. Now, of course, the patient with an endoleostomy may not need a significant bowel regimen, but you should still be asking yourself the question. And for every patient, you should be checking if they're having bowel movements. Again, ileus and constipation are very common in the ICU population for a variety of reasons, as is Ogilvy's. And the last thing that you want to do is miss a significant colonic distension or constipation that goes on to progress to a perforation. So every day, make sure things are moving. And then finally, see if they need to be assessed by speech and swallow service, because if the patient's been extubated, but they were intubated for a while, or if they had a head injury or other reason to be concerned about their ability to safely swallow, then that might be something that you need to obtain. From a hematological standpoint, again, knowing the trends is very valuable. Hemoglobin and hematocrit. There's lots of data, best practices for indications for transfusion. And if there's not an obvious indication, then that may be something to discuss with a colleague or on rounds. You do want to know if the patient's received any transfusions in the past 24 hours so that their lab data can be looked at in the appropriate context. Likewise, for the platelets, knowing the trend is extremely important. You might not think much of a platelet level of 150, but if 3 days ago it was 450, you want to think about why and whether you need to be concerned about HIT if they are on heparin products. Additionally, you want to look at their last coags. If their last coags were a few days ago, but there's no reason to expect them to be abnormal, then you don't necessarily need to repeat them. But again, if there's concerns about liver failure or multiple transfusions or any other reason to check, certain medications like Coumadin, then you want to make sure you have those. You want to look at whether they're on anticoagulation and what parameters are being followed, and whether they're therapeutic. So knowing that they're on a heparin drip doesn't do any good if you don't know that their PTT is therapeutic. And likewise, you also want to know if they have indications for anticoagulation that has been held. So DVT, PE, atrial fibrillation, diagnoses from home or new diagnoses this hospitalization. You want to look at why the anticoagulation is being held and if it now can be resumed. And that should be a daily question. And oftentimes you're asking that question of other specialists who are the ones who are saying no. Do also document that they said no and what their anticipated time frame is for when they can resume it. And then for some patients, TEG or ROTEM, thromboelastography or thromboelastometry are going to be helpful, particularly in a patient who's had a recent massive transfusion and maybe is still oozing a little bit, or especially in a patient with chronic liver failure. From an infectious disease standpoint, this can often be a big chunk of the patient's plan as well, depending on their diagnoses. So make sure that you've looked at their Tmax for the last 24 hours and also their white count and the trend, and that includes the differential on the white count. So if they've got a significant bandemia, that's something that you should definitely be paying attention to. You should be looking for any potential undiagnosed or inadequately treated infection. Your workup should match your differential diagnosis. And if the patient's becoming unstable and you think that they may be septic, then do make sure you're referring to the surviving sepsis guidelines and following those. Look at the most recent culture data. This is something you should be doing daily because it frequently updates. And you should be looking at the current antibiotics. And when you're presenting antibiotics, that should include what the antibiotic is, what the day of treatment is, the reason for treatment, and the plan for the duration. For example, the patient is on day 4 of 7 of vancomycin for MRSA pneumonia. You do want to look at whether those antibiotics can be de-escalated based on culture data. Do any further cultures need to be ordered? So if they had a recent bacteremia and there's been no negative blood cultures yet, perhaps you need to order them. And you should always be looking at whether antibiotics can be discontinued, along with any other medications, to try to avoid polypharmacy as much as possible. From an endocrine standpoint, you want to look at their glucose levels. Generally in the ICU, we are satisfied as long as they are under 180 without periods of hypoglycemia. And that's good enough to just simply say on rounds that they're euglycemic. If the patient's hyperglycemic, you should be asking yourself if the sliding scale should be increased or if any long-acting insulin can be added. If they're on a sliding scale but receiving a lot of coverage, you may also ask yourself the question of whether long-acting insulin should be added. If they're very hyperglycemic, say in the 300s or 400s, then you should be thinking about an insulin drip. You also want to pay attention to any other endocrine pathology requiring treatment and whether those home medications are on. So are they on home Synthroid? And you also want to ask and look into whether the patient's on steroids. So if they were started on steroids empirically as part of septic shock, then you should always be asking, can they be stopped? And similarly to other things, you want to double check that they weren't on steroids at home. If they were, maybe they need a stress dose. Certainly they shouldn't be stopped. So all of those things need consideration. From a skin and musculoskeletal standpoint, again, knowledge of any pressure ulcers is important. Their out of bed status, their weight bearing status, even if they're vented, we can still get them out of bed. So that should always be encouraged. And it's our job as providers to encourage that and advocate for the patient, because that will help them to do better. And finally, following up from other services, particularly in the trauma population, lots of orthopedic operations happen, and knowing when those are likely to happen is very important. Rounding it out with prophylaxis, you should always be asking if they're on appropriate DVT prophylaxis. Sub-Q heparin is typically used with acute kidney injury patients, but for all others, you should really be trying to use Lovenox. It's a little more reliable and also less frequent typically. Make sure that you're dosing appropriately for higher risk patients, particularly trauma, obesity, cancer, and you can discuss with your pharmacist what an appropriate dose is for your patient. You should also look at whether the patient's on GI prophylaxis and whether it is indicated. So it may be institution specific what the preferred agent is, but the question is mostly, do they need it or not? So our typical indications for GI prophylaxis are going to be trauma, head injury, burn, or sepsis. But that doesn't mean that, you know, every little head bonk or finger burn requires GI prophylaxis. So typically we use intubation as a surrogate for the severity of these diagnoses. And if they're requiring intubation or mechanical ventilation as a result of these diagnoses, then they should be on GI prophylaxis. And once they have stabilized enough such that they no longer require mechanical ventilation, then typically that's a time when you can discontinue it. However, that may also be intensivist specific or institution specific, and so do make sure you know your environment. Finally, make sure you double check that they weren't on it at home. So if they're on a PPI at home for GERD, make sure that they remain on that and that you don't discontinue it. And hopefully you're picking up a theme here that home medications are incredibly important to pay attention to. So just because you're taking care of an ICU patient doesn't mean that you forget about all of their chronic maintenance medications, and that should be something you check every day, particularly if it's a patient that's new to you. Look back to their incoming medication reconciliation, because most likely they had a lot of medications that were held, and every day you should be looking at whether those can be restarted. Finally, ventilator-associated pneumonia prophylaxis is usually automatic or part of an order set when the patient's on a ventilator, includes mouth care and other nursing things. Finally, for the patients, it's very important to consider their lines. So we're most interested in central lines. However, all lines should be evaluated, listed, noted. You need to know where the patient or where the line is within the patient. So the site, IJ, subclavian, etc. The date of insertion, very important. And sometimes you have to do some detective work to find that out. And then most importantly, the indication. So it used to be that we would routinely change lines every week to decrease the risk of infection. And that really didn't bear out. And the guidelines have changed. And now the guidelines basically say that the duration of the line being present is not a reason to change it out in itself. So lines that are needed that don't have evidence of infection should stay. But the caveat is that attached to that statement is the statement that you should get lines out as soon as there's no longer an indication for a central line. So some people like to practice the first half of that, but conveniently forget about the second half because it is convenient to have a central line. It certainly makes blood draws and access a lot easier. However, we really just don't have the margin to accept any central line infections. And so every day you should be presenting, okay, the patient has a right IJ catheter placed on such and such date 3 days ago, and it is still present because he is on pressors. And so all of those things should be noted. PICC lines as well, they count as central lines from an infectious standpoint and also from a keeping track of central line infections as a hospital and unit standpoint. Midlines don't quote unquote ding us when they become infected. So midlines are a long catheter placed in the periphery, similar to a PICC line, except they don't go all the way central. They usually end in the subclavian or so, or maybe just a little bit less than that. And so while they don't ding us for line infections if they become infected, that doesn't mean that they don't hurt the patient if they become infected. And so you still want to be thinking about those critically. Arterial lines, much less risk for infection, but if you don't need it, you may consider removing it. And then I didn't put it on here, but temporary dialysis catheters should be considered as well. Oftentimes it's apparent when they need to be maintained or not, but you may consider trying to get those out as early as possible as well. Last thing, when you're determining your plan for the patient is the disposition. So you should be asking yourself, what's preventing the patient from progressing to the next level of care or going to the floor? And those are the things that you should be working on in advancing the care of the patient. So rounds are over. The things that you need to do after rounds, make sure that all of the orders that you discussed on rounds were actually placed. Follow up on any changes that you made for the day, the vent changes, the follow-up gases, additional vent changes, labs that were being replaced, additional follow-up electrolytes. Update the patient or the family as appropriate, especially in this current era where visitation is extremely limited. That means making a phone call, even if you weren't asked to do so. It's good to touch base every day and makes the conversations easier later on as if they become more difficult. And then finally, as you're getting ready to head out for the day, check on the patient one last time. Make sure there's no surprises, nothing else that's come up. And then finally, give the on-call or the night person a good sign out. So what has changed since rounds? What were the follow-up results of things from rounds? And what are things that they need to either follow up on or watch out for the evening? That concludes the presentation. Good luck as you embark on your participation in ICU care.